In this final lecture on diabetes mellitus treatment, I'll cover insulin therapy. We'll talk about basal and bolus insulin and some of the common insulin dosing strategies. So let me talk a little bit about the history of insulin therapy first. Insulin was first discovered actually, Paul Langerhans, a medical student in Germany in the late 1800s, observed, he's the one that discovered the Langerhans, the islets of Langerhans, and it was in the coming decades, researchers figured out that the islets were secreting some hormones and that these hormones were involved in diabetes. Lack of the islands resulted in type 1 diabetes. But it wasn't until 1921 when I believe it's Friedrich Banting and his laboratory assistant Charles Best first isolated insulin and purified it. In the following year, they're actually able to treat a patient with type 1 diabetes with a purified extract with this. Once they figured out the extraction and everything and the structure of insulin was discovered, then after that, researchers started and physicians started using it in medical practice. Interestingly, Banting and Best offered their research results for free to the world, and it's kind of disheartening to see that many of the insulin companies are now charging these exorbitant prices for their insulins. So that's regular insulin. Now, before the 1980s, most of the insulin therapies actually used that were used for humans were derived from cow, horse, pig, or fish pancreases. So these sources are nearly identical to human insulin, but there are other peptides in there, and they often cause severe allergic reactions. As you can imagine, you need a lot of cow or pig or horse pancreases just to get a little bit of insulin. So insulin was extremely expensive and not available to most people. So most people with type 1 diabetes died because of the lack of insulin. But in 1982, the Lilly company, Eli Lilly, developed through genetic engineering and recombinant DNA technology, they're able to make bacteria, E. coli, manufacture insulin. And that became one of the first sort of semi-synthetic insulins, and that was Humulin. So that was the first non-regular insulin that was marketed. And then since then, researchers have developed a whole series of different insulins that have different half-lives. So we have regular insulin, but then we have insulin analogs, and they all have different half-lives. Some of them very short half-lives, and those are very good for taking right after a meal to balance blood sugar. But then there are the basal insulins, which have a 24-hour or longer half-life, which can be used for basal levels. Insulin is, again, injected because it's a peptide. It can be taken intranasally, and there have been a few intranasal forms. I don't know if there's any really currently out there. As you can imagine, sniffing it up your nose every day is not very convenient. But for people who don't want to do injections every day, that's a potential option. There are the classic injection method, just with the syringe. But now there's a lot of insulin pens. I have noticed that a lot of insurance companies like OHP will not cover the insulin pens, but they'll do the regular insulin injections. And then increasingly we have insulin pumps. And these are usually little catheters that are inserted subcutaneously. And then the pump is loaded usually with regular insulin or short-acting insulin, and that is infused at a constant rate. And the user can adjust the pump insulin level and the rate of delivery based on their estimates of how many carbohydrates they ate and so forth. And these patients are still regularly checking their blood glucoses. So typically with insulin, blood glucose has to be checked several times a day, and that's usually with a finger stick, and then they can regulate their insulin based on that. There are new technologies where you have indwelling glucose sensors, and typically they last up for about a week, and they need to be taken out and replaced, but they're inserted through a little catheter again in the skin, and they can rest in place and monitor glucose that way. And I think we're going to see better and better technology there. And sort of the next step in the technology will be to make a fully what's called closed loop system, which is to have the continuous monitoring of glucose, and that tells the pump essentially how much insulin to put out so that the user doesn't really have to interact with that at all. But right now, the insulin pumps still require a lot of user input for them to function properly. So that's the different types of insulin therapies. And so we need to look at what all these insulin analogs are and what their different half-lives and when might we think about using them. So we can classify the different insulins into rapid or short-acting, intermediate-acting, and long-acting. So regular insulin, regular human insulin, is short-acting. Again, all of this is usually obtained through genetic recombinant DNA technology, usually from E. coli. I think that's the most common bacteria that's used to synthesize the insulin. Short-acting is given subcutaneously or intravenously in emergencies. It rapidly lowers blood sugar, and we see peak action about an hour up to 2 hours after the injection, and it's active for up to 8 hours. So that's regular insulin. Then we have very rapid acting. They're more rapidly absorbed than regular insulin, and we call these bolus insulin. So when you hear the word bolus insulin, that usually refers to the Humalog, insulin Lispro, Novolog, insulin Aspart, or the Apidra, which is insulin glulisine. So these are your bolus insulins. They tend to be less associated because they have such a short half-life with hypoglycemia. We see peak levels within 30 to 90 minutes after injection, and they're typically used with a longer-acting insulin for optimal glucose control. So we wouldn't never just give a bolus insulin without there already being a basal or longer-acting insulin on board. And this kind of mimics the postprandial release or prandial release while you're eating of insulin from your pancreas. And these are the ones that are often used in those insulin pumps that I just talked about. So that's the rapid-acting insulins. The intermediate-acting would be the neutral protamine hegedorn, which is NPH insulin. And this is a suspension of insulin combined with protamine, which is a polypeptide, and that delays the absorption of insulin. Starts working within 1 to 3 hours, and it's active for up to 24 hours. So this is used usually for basal control, and it's often combined with a rapid or short-acting agent for mealtime control. There's a related preparation, which is called neutral protamine Lispro, NPL insulin, and it's used only with the insulin Lispro, so only that bolus insulin. Okay, so that's NPH, intermediate acting insulin, and then we have our long-acting insulins, insulin glargine, Lantus, and insulin detamere, Levemir. These are microcrystals that release insulin over 18 to 26 hours. We call this basal insulin. So when you hear the word basal insulin, that's what they're talking about. Usually requires a bolus insulin as well around meal times. But as we'll see with type 2 diabetic patients, sometimes we just do the basal insulin, no bolus, as our first step when we go into insulin therapy. Now, anytime you use an anabolic hormone, in this case insulin, there's always an increased risk of cancer, and the evidence is conflicting on this, but you know, this is the kind of thing where we have to weigh risks versus benefits, but I just put that there as a question mark. But these are the basal insulins. Then there are various combinations, so we can have 70% NPH with 30% regular, and 75% NPL with 25% Lispro, etc. I won't be talking much about those, and I don't know of a lot of people using those. The idea there is you're going to get better control when you combine these two, but it takes a little bit more futzing around to kind of get the right dosage. So the standard insulin therapy is to really inject insulin twice a day, do a basal insulin once a day, typically, and then maybe a bolus 1 to 3 times a day on top of that. So here's a graph kind of showing the Levemir and Lantus, seeing the very long half-lives, and then the NPH kind of intermediate, regular, and then we have our bolus insulins here. Adverse effects, obviously hypoglycemia much more than sulfonylureas, and that's typically from insulin overdose, very common cause of hospitalization. So patients that if you're giving insulin for patients, if you're in primary care and doing that, you need to have the whole discussion with them about what to do if hypoglycemia happens. They have to have something sugary around to be able to get a quick glucose bolus, and hopefully that will help stabilize their blood sugar. Weight gain is associated with long-term insulin use. Lipodystrophy around the injection sites, that's accumulation of fat tissue, and then potential allergic reactions, especially with some of these insulins. They're very purified now, but there are some different peptides in there which some people might have allergies to. So those are the different types of insulin, and short, intermediate, and long-acting insulin, and some of their half-lives. Now, I'm not going to go over the details here of actual dosages for, starting a basal insulin, how many units of insulin, and then with bolus insulin, how many units per gram of carbohydrate and so forth. That's a little bit more advanced training. So I'm not going to go over that here, but that's something if you're interested in. There are a lot of seminars. If you're in the endocrinology class, we're going to try to have a speaker on that so you get an overview of how that's done. But a lot of even primary care physicians don't do insulin therapy to this level because it does require specialized training. It requires a lot of good communication in place when patients have problems. They can reach you and reach your staff for help and so forth. But I'll just talk a little bit about again, in type 1, we're going to do a basal insulin with usually bolus insulin 3 times a day. Patients are checking their glucose levels with finger sticks up to 5 times a day sometimes, and adjusting the bolus insulin to kind of get their glucose down. But typically for type 2 diabetes, after we've exhausted the oral hypoglycemic agent route, a basal insulin is usually begun, typically with metformin. So we'll start with basal insulin only. And typically that will be enough. But if that doesn't bring about control, then sometimes a mealtime bolus insulin will also be injected. So we start getting more complex regimens where we get the basal insulin and then we use bolus insulin at each mealtime. So that's some of the different strategies that are used. I've just put here from up to date in 2019, kind of the, in terms of the units that one can start with, and then the kind of algorithm for how to think about that, so you can read through that. But again, I won't be focusing on that in too much detail here, but it is important to know the difference between the basal and the bolus insulin, when we use it, and what the differences are between dosing and strategies for dosing between type 1 and type 2 patients. Okay, so that wraps it up. That is a summary for all diabetes treatment, and this is the final lecture in the diabetes series.